Hi, this is Brian Cornelius. I'm talking about a study we did on a retrospective analysis of calcium levels in pediatric trauma patients. This study was conducted at Ochsner LSU Health in Shreveport, and I'm very appreciative to my co-authors from the Department of Surgery, Emergency Medicine, and the LSU campus of LSU University for their work with our statistical analysis. I have nothing to disclose. Unfortunately, I'm not making any great money off of this. I have no conflicts of interest. And these are our views and do not reflect the official position or policy of our employers. So as we're all aware, there's a significant number of pediatric trauma patients that die each year from unintentional injuries. Calcium is an important component of coagulation, platelet aggregation, thrombus formation, and cardiac contractility. When you actually start looking at hypotensive trauma patients that are bleeding, it may be pretty beneficial for them. And we know that derangements in calcium level worsen outcomes in patients that are already at risk of developing hemodynamic instability due to the lethal triad. And in fact, there's a suggestion in the adult world that we transition to the deadly diamond to add in hypocalcemia. Hypocalcemia has also been associated with the need for increased blood products and mortality. Up to 50% of adult trauma patients present with hypocalcemia. And what we found when we started looking at this was there was no literature discussing the incidence of hypocalcemia in pediatric trauma patients. So that was where we kind of took off. Over an 8-year period, we looked at all the pediatric trauma patients coming into our institution. We collected the initial serum calcium, ionized calcium if available, albumin, and INR. And then we also looked at whether they required operative intervention, which we defined as OR or IR within the first 24 hours, received calcium, the type and amount of blood products transfused in the first 24 hours, and if the MTP was activated. Exclusion criteria were receiving calcium prior to hospital arrival, pregnancy, and incomplete data. So we had almost 3,000 patients in that time period that met criteria. We excluded about 1,600 of them. 48 arrived without signs of life and no labs were obtained. On the other end of the spectrum, we had low acuity patients, primarily isolated orthopedic injuries that came in that didn't have labs obtained either. And then we had a small number of pregnant patients. I was kind of surprised it wasn't higher than that. So with our study, we were left with a decent size, 1,305 patients. The vast majority lived, 1,256, 49 ultimately expired. And then we did a subgroup analysis with patients that required operative intervention, transfusion, hypocalcemia, and we called it hypocalcemia on the basis of a calcium level less than 9, which is our institutional cutoff. Our primary outcome was just to determine the incidence of hypocalcemia and severe hypocalcemia in pediatric trauma patients. Our secondary outcome was to look at the impact of hypocalcemia on the rate of transfusion, operative intervention, and mortality. And we use these outcomes for subgroup analysis. We utilized descriptive statistics for the entire sample. As I said, we did subgroup analysis for those 3 cohorts, and they were divided in class based on outcome measures. And we utilized multiple statistical processes as we looked at our data. So epidemiologically, the mean age of the survey size was 8. Our patients that were hypocalcemic or received blood transfusion were a little bit older. All the samples were primarily male. Patients that required transfusion had a significantly higher initial ISS. The hypocalcemia group and required trips to the operating room group were slightly higher than the overall group. Of note, there was an increased rate of penetrating trauma in the transfusion group and also an increased mortality rate in that group. The other interesting thing is their presentation GCS was lower, so we attributed that to some neurologic sequelae, either as a primary injury or secondary to the hypoperfusion. A little bit different perspective for you, just kind of seeing how things lay out there. And one thing that we kind of ran into issues with, due to the age range, we'd originally planned to calculate shock index. We were unable to do that because of the age rate related variability in the population. So the heart rate and blood pressure were kind of excluded from data analysis. These are the calcium levels by cohort. Overall, 8.73. The patients that lived had higher calciums than any of the other subgroups. Those that died were lower, so there may be an association there. Those that were transfused were almost in line, and when we looked at the subgroup of patients that were already hypocalcemic, they were on the lowest end of all. Giving you a side-by-side comparison when we look at the groups, as you see, the transfused group had the highest mortality rate. We looked at morbidity, which we defined by length of stay. The transfusion group, which was obviously the sickest of the cohorts, had the longest lengths of stay. Obviously, they all had MTP activated. Looking at the other two groups, what we found was that the patients that required operative intervention stayed a little bit longer, and the overall population was on the short end. So all three cohorts wound up staying a little bit longer than the overall population. So looking at the subgroup analysis, the mean ISS of the patients with calcium less than 9 was almost 15, 5% mortality rate, a fairly long length of stay, 8.5 days, mean GCS of 12.5. Almost half the group required blood products, significant number required trips to the operating room, almost 40%, and a decent number received calcium replacement, but not quite as many as probably needed it. On the other end of the spectrum, we looked at the hypercalcemic patients, and we found that they did fairly well. Their ISS was low, there were no mortalities, and they had a very short length of stay. We attribute part of this to citrate chelation. We know the transfusion drops your calcium levels significantly, but there's a possibility that some pre-existing pathophysiology contributes to hypocalcemia in trauma patients. So conclusions, pediatric trauma patients present with hypocalcemia. There's an increased rate of hypocalcemia in patients requiring transfusion, and hypocalcemia is associated with increased morbidity and mortality. Thank you, and I'll take questions.